And voice is voice.
Yeah, very clear, Doctor.
Okay, thank you. Shukran, Jazakallah.
Thank you, Doctor.
Okay, so I request all of you to write your name in the chat box so that your attendance can be noted. I'm not going to take the screenshots. I will record the attendance from the chat box. So don't forget to write your name in the chat box. One more announcement is there. This session may end after 40 minutes. Please log in back if it ends before the completion of the lecture. So I'm going to start. Just again, I will request all of you to write your name in the chat box and mute your mic so that there should not be any disturbance. Only 10 people has written their name in the chat box. Still 4 people has to write their name, and whoever comes afterwards, please write your name. I request you to tell them. Okay, I will start this lecture. Bismillahirrahmanirrahim. So today's topic for our pharmacology lecture is anti-inflammatory. I have written, I given a gap between anti and inflammatory. So these are the drugs which are used to prevent inflammation. Now, you must have studied inflammation in the pathology lab. So you know that inflammation is a normal protective response to tissue injury caused by the physical trauma or noxious chemicals or the microbiologic agents. And this inflammation is the body's effort to inactivate or destroy invading organisms and remove irritants and set the stage for tissue repair. And generally it subsides after the healing. But so why we need anti-inflammatory drugs? Why we are interfering with the process of inflammation? Although it is good for us, but we need anti-inflammatory drugs because inflammation sometimes inappropriately triggered by some noxious agents such as pollens or by autoimmune response, such as in case of asthma or rheumatoid arthritis. So in this case, in such cases, the defense reaction themselves causes progressive tissue injury, and thus anti-inflammatory drugs are required to modulate the inflammatory process. So during this lecture, we will be covering following objectives. First is classify the anti-inflammatory drugs, explain their mechanisms of action, and outline the role of anti-inflammatory drugs in ameliorating inflammation due to different mediators. So first of all, we will start with this slide. I request all of you to write your name in the chat box, those who have came late. Okay, so you remember this, slide. You must have studied this in the pathology. And you must have studied also that there are various chemical mediators which are playing important role in inflammatory process, such as, for example, there are various type of chemical mediators vary with the type of inflammatory process, such as lipids, lipid type, example, prostaglandin, small peptides, such as bradykinin, and large peptides such as interleukin-1. So if you see the origin, most of them are originated, the precursor for them is arachidonic acid. And this arachidonic acid is present as a component of phospholipids of cell membrane, and it is released by the enzyme phospholipase A2. Now, this arachidonic acid is acted upon by various isoforms of cyclooxygenase enzyme, and it may lead to formation of PGI2, prostaglandins, and thromboxanes. And arachidonic acid can be converted into leukotrienes by the lipooxygenase. So we are not interested in this this pathway. We are interested in this one. So how can you prevent? Because we know these prostaglandins are one of the type of chemical mediator for the inflammation. So either you can inhibit the cyclooxygenase so that it will not be converted into these. But what will happen if cyclooxygenase are not acted upon? Then lipoxygenase will work and it will convert it into leukotrienes, and it will be having potent bronchospasm. So it will be difficult to give to the asthmatic patient. Now, come again. So you can either inhibit cyclooxygenase, or second option is you can inhibit phospholipase so that arachidonic acid will not form. That's what our anti-inflammatory drugs do. So we will see this in the coming slides. So let's come to the classification. So first, these are classified into, based on their chemistry, steroids and non-steroids. So these are having steroidal drugs are having steroidal nucleus, which is cyclophenanthrene ring, and they can be they are further classified into glucocorticoids or mineralocorticoids. Out of these glucocorticoid and mineralocorticoid, only glucocorticoid have significant anti-inflammatory effects. That's why these when we study about the steroidal drugs, we will study only about the glucocorticoids and its effect, how it produces its effect, anti-inflammatory effects. Regarding second, non-steroidal anti-inflammatory drugs, these are the drugs which consist of various type of, so they are not having single core nucleus. They are heterogeneous group of drugs. So some may be salicylates, some may be phenamic acid type of drugs. So they have different chemical structures, and we will classify them according to that also. They have a potent anti-inflammatory effect. They have antipyretic effect, that is, they lower the high body temperature, and they are also having analgesic effects. So as I said in this slide, you can either inhibit cyclooxygenase to prevent the formation of prostaglandins, or inhibit phospholipase. So let's see what happens. So if you are using glucocorticoids, it inhibits the phospholipase A2. So by producing annexin 1, this is also called lipocortin. This we will discuss in coming slide in detail also. So glucocorticoid inhibit the formation of this annexin 1 and decrease the activity of phospholipase by increasing the production of annexin 1, and also it inhibits induction of cyclooxygenase enzyme. So main action is because of inhibition of phospholipase, but it also have it also affect the cyclooxygenase. Regarding the non-steroidal anti-inflammatory drugs, they may be non-selective and selective, and they inhibit cyclooxygenase enzyme. So altogether, they decrease the production of chemical mediator for the inflammation. Let's see about the first class of the anti-inflammatory drugs. These are steroids. And as I said, glucocorticoids have the anti-inflammatory effect. So we will study only about the glucocorticoids. So these, how they produce their effect is, these bind to the cytoplasmic receptors. These are mobile receptors, steroidal receptors. These bind to the cytoplasmic, enter the cell and bind to the cytoplasmic receptor. This complex will transfer into the nucleus, and then they bind to the DNA and cause transcription and formation of mRNA, and ultimately by translation it may lead to formation of some protein which suppress the phospholipase A2. So what is that protein? That is one of the mediator is annexin 1, that is also called lipocortin. So its effect is produced by formation of lipocortin, which inhibits phospholipase A2 and which results in inhibition of prostaglandin, leukotrienes, and platelet activating factor effect. Second effect is it decreases the synthesis of leukotriene 1 and tissue necrosis factor alpha and other mediator of inflammation. So if question is asked, what is the mechanism of action of glucocorticoid? So you have to write about this, all this. So if you see the anti-inflammatory effect of these glucocorticoids, it is it produces its effect not only by those factors which we have seen, but other things are also there. First is effect on the inflammatory cells. So it inhibit decrease migration of neutrophil and monocytes at the inflammatory site, then decrease the function of neutrophil and macrophages. So ultimately it inhibits phagocytosis and is the synthesis and release of inflammatory mediator. We have already seen this in the previous slides. So it decreases prostaglandin and leukotriene synthesis by inhibiting phospholipase A2 enzyme, by lipocortin or annexin 1, and by inhibition of induction of COX-2 also. Then it decreases the synthesis of cytokines, interleukin 1 and TNF alpha. It also stabilizes lysosomal membrane, so there will be decreased release of lysosomal enzymes. Now, because the membrane should rupture to release the lysosomal enzyme, so there will be decrease in the cell death. It also decreases blood vessel permeability, so that there will be lesser edema, and this is permissible effect on noradrenaline. Regarding the these glucocorticoids also have some anti-allergic effects also. This is because of decrease in antigen processing by macrophages. So there will be decrease in antibody. When there is decrease in antibody formation, there will be lesser antigen-antibody reaction. And these glucocorticoids also, you must know that there is histamine also is released in case of allergy. So it decreases mast cell and cell basophil membranes and decreases the vasodilation also. So altogether, it decreases tissue response to allergic mediators. So it is having anti-inflammatory effect. It is having, these glucocorticoids have anti-inflammatory, anti-allergic, and third one is anti-immunosuppressive effect also. So in case of autoimmune diseases such as rheumatoid arthritis, you can give it because it decreases synthesis and induction of apoptosis and the action of T and B lymphocytes. So ultimately, it decreases the concentration of circulating lymphocytes. As we have seen, it decreases interleukin 1 and other chemical mediators which were involved in delayed cell-mediated hypersensitivity and injection reactions. So this can be of drug of choice for the immunosuppressive effects. Besides these effects, these glucocorticoids may have some other effects also. And these effects may be desired or may not be desired. For example, they have effect on metabolism. So let's see effect on carbohydrate. The CHO is we have written for the carbohydrate. So it raises the blood sugar level because these glucocorticoids decrease uptake and utilization of glucose and causes an increase in gluconeogenesis. So this may lead to hyperglycemia. That's why these are contraindicated to the patient who are having diabetes mellitus. Second is effect on the protein. So these glucocorticoids increases protein degradation and decreases protein synthesis. So it increases the protein degradation and decreases protein synthesis. So mostly the effect is on the skeletal muscle. That's why there is decrease in the muscle mass, those who are taking glucocorticoids for a longer time. Regarding the lipids, they interfere with the lipolysis and lipogenesis. That's why there will be redistribution of the lipids, and generally there will be accumulation of lipid within the adipose tissues. So it may have, the person may be having buffalo hump. We will see in the next coming slide what is this buffalo hump. Then leptin effect, it decreases the leptin effects. What is this leptin? Leptin is also called satiety hormones. So its effect is, it gives a satisfaction after eating the food that now no more food is required. So person will not eat. But these glucocorticoids decreases its effects, and person will be having hunger, and he takes more energy. Next effect so we do not require all these effects. So long-term use of glucocorticoids may lead to these effects. Next is effect on the bone. It may lead to osteoporosis by decreasing calcium absorption and increasing excretion, along with increased breakdown of bone matrix. So this is also undesired effect. Regarding the central nervous system, they have insomnia. They may produce insomnia, euphoria, depression, and increase in intracranial pressure. If you see their effect on the blood, they decrease circulating cells such as basophils, eosinophils, monocytes, and lymphocytes. So the acute effect is redistribution of these cells to the lymphoid tissue. And in chronic effect is increased apoptosis. They also cause increase in polymorphonuclear leukocyte due to decreased migration and function. They may also increase in the RBCs and platelets and leads to phagocytosis. Regarding the skeletal muscle, although they are necessary for the growth of skeletal muscles, but excess may cause wasting, or you case myopathy, because of the catabolic effect on the protein. Then in case of eye, it causes increased intraocular pressure. So you cannot give it to those patients who are having glaucoma, and it precipitates cataract also. Then hormones, it decreases the concentration of release of ACTH, LH, and growth hormone. On the kidney, if it is used, although it is required for the glomerular, essential for the glomerular filtration rate, but if it is used in excess or for a long time, it may lead to sodium and water retention. So what will happen? This is the basic reason for their cardiovascular effect. Now, if you see this, some of the glucocorticoids also have some mineralocorticoid effect, that is retaining the sodium retention and water retention effect. So if you see cortisol, which is the natural hormones, it is having equal anti-inflammatory effect and a sodium retention effect. Now, we don't want our anti-inflammatory drugs or steroidal anti-inflammatory drugs to have mineralocorticoid effects. That's why research was going on. And if you see, these are having 25 times more anti-inflammatory drugs effect than the cortisol, this dexamethasone and it is having no sodium retention effect. So it will not affect the cardiovascular system. So these are better one than the cortisol itself. So as we have discussed various effect of steroids, so they may lead to adverse effect of these steroids. So if you are giving to someone the effect on the CNS, we have already seen it may lead to euphoria, dysphoria, increase intracranial pressure. Because of effect on the lipids, it may lead to, we have seen, it may lead to redistribution of fat to the adipose tissues, especially it may lead, so the symptoms is moon face, buffalo hump. You can see this back is like the buffalo, and increased abdominal fat and truncal obesity. Regarding the eye, it may we have seen it may precipitate cataract and cause increased intraocular pressure, so it may precipitate glaucoma. Skin, it may lead to hirsutis, thinning of skin, easy bruising, muscle wasting due to prolonged use, and myopathy, then bone osteoporosis, especially the avascular necrosis of the head of the femur, then increase in blood pressure, increase in peptic ulcer and bleeding. It may lead to hyperglycemia because of effect on the carbohydrates. It may increase the appetite because of suppressing the effect of satiety hormone, that is leptin. It may increase susceptibility to infection. It may have adrenal suppression, delayed growth of children, poor healing of wound. Sudden withdrawal may lead to hypotension, hypoglycemia, and shock. So it is having so many side effects that its use is based on the risk assessment. You have to assess the risk and the benefit. Risk-benefit assessment after the assessment. So that's why the scientists were constantly looking for those drugs which are safer and have lesser side effects. So since we have, we will see about non-steroidal anti-inflammatory drugs. You have seen this adverse effect, so you can justify their contraindication and precaution in use. First is peptic ulcer. So generally the use of glucocorticoids is associated with increased peptic ulcer bleeding. This is seen with mild to high dose, but not with the low dose. It may also be leads to increased risk of heart failure due to hypertension and dyslipidemia. And third one is increased blood pressure, because these glucocorticoids causes hypertension through several mechanisms, which may be due to intrinsic mineralocorticoid activity, or through the activation of renin-angiotensin system, or by enhancement of vasoactive substances, and by causing suppression of vasodilatory system. So altogether, these are not suitable for those patients who are having heart diseases. Next, about the diabetic mellitus, as we have already seen that it may cause decrease in uptake and utilization of glucose and increase in gluconeogenesis, resulting in tendency to hyperglycemia. That's why they are contraindicated in case of patient having diabetic mellitus. Rest, as we have seen in previous slide, that it suppresses the immune system. So the person are more susceptible to infections such as tuberculosis and varicella virus infection. Psychosis, they are having euphoric and dysphoria, increase in intracranial pressure. They are not suitable for the psychotic patients. Euphoria and psychosis with short-term administration, and depression with chronic treatment is seen in the patient. It may increase the intraocular pressure, we have seen. So it is contraindicated in glaucoma and also in those patients who are having a risk of development of cataract. It should be given with precaution or should not be given to the old patient because of risk of osteoporosis. Now, so you have seen that the steroidal anti-inflammatory drugs are having so many side effects that the risk is more than the benefits. That's why the scientists were constantly looking for the safer options, and when they studied about the mechanism or production of cytokine or chemical mediators, they came up with some very good options. These are called non-steroidal anti-inflammatory drugs. So, as we have seen, that the arachidonic acid is the precursor for these prostaglandin, thromboxane, and this is generally produced by the cyclooxygenase enzyme. So cyclooxygenase are having many isoforms, COX-1, COX-2. So when COX-1 arachidonic acid, it works on arachidonic acid, it produces prostaglandins, which are responsible for protection of stomach, kidney, and uterus. Thromboxane is also produced, which is required for normal platelet effects. Okay, if arachidonic acid is acted upon by the COX-2, it forms prostaglandins, which produces inflammation, pain, and fever. It may prevent thrombosis, and it protects normal kidney functions. So we want to suppress this inflammation, pain, and fever, inflammation. So we can suppress cyclooxygenase enzymes. So we have some drugs which are called non-selective, non-steroidal anti-inflammatory drugs, which suppresses both COX-1 and COX-2. So what will happen? There will be no protection of the gastric mucosa and kidney. So there will be peptic ulcers or GI side effects. There will be impaired platelet function, and there will be bleeding. And also, but if you see, because of COX-2 inhibition, there will be inhibition of inflammation, pain, and fever. But it may lead to thrombosis also and impaired kidney function. Now, these were the initial drugs, and these are cheaper one, and now available also. We are using all these type of drugs also. But then the scientists develop don't want these side effects, so they developed selective COX-2 inhibitors. These selective COX-2 inhibitors are inhibiting only COX-2 isoform of the cyclooxygenase enzyme. So it inhibits the inflammation, pain, and fever, but it is having two other effects, that is thrombosis and impaired kidney function. But if you see, compared to this one, the kidney function impairment in kidney function is lesser than in case of non-selective anti-inflammatory drugs. So these are, and there is no effect on the mucosa and kidney, and there will be no effect on the normal platelet function. So COX-2 is better than the one. But the problem is, when the COX-1 is not working, more of the arachidonic acid will be converted into, if you remember the first slide, this one. So it will be acted upon by lipooxygenase and converted to leukotriene, which causes potent bronchospasm. So that's why COX-2 are generally not preferred for those patients who are having these asthma. So I think this is clear for you. Now we can proceed for further. One announcement is there. This meeting will end in 10 minutes. You should log in as soon as possible because there's still many slides are there to be discussed. So I will log in again and you will also log in again. So these non-steroidal anti-inflammatory, as we have seen, can be divided into, is acted upon by these act on the cyclooxygenase enzyme. So cyclooxygenase enzymes divided into COX-1, which is constitutive, means it is already present in the normal condition, whereas COX-2 is inducible. It will be induced only when there is inflammation at the inflammatory site. So COX-1, especially in stomach, HCl and kidney, and causes, stimulated by HCl and causes prevention of peptic ulcer, and in kidney is causes vasodilation and diuresis of sodium and potassium. COX-2 is inducible. It will induce only when there is inflammation. So when there is inflammation, toxins are produced, cytotoxins are there, which induces, such as interleukins, anti-NF-alpha will induces COX-2, and it prevents it increases prostaglandins, especially E2 and I2. Then decreases the effect. Then CNS, it is having effect on hypothalamus, heat regulatory center, and it suppresses the fever. In thalamus, when it works on thalamus, it suppresses the pain. Peripherally, prostaglandins are responsible for pain and inflammation and sensitizes nociceptors to histamine, bradykinin, and serotonin, and these are responsible for the pain. Potentiate effect of histamine and bradykinin. These cyclooxygenases enzyme potentiate the effect of histamine, bradykinin by vasodilation. So there will be the cardinal sign of inflammation, dolor and color, and increases capillary permeability, so leading to swelling and tenderness. They also enhances other cytokines. So COX-2 is responsible for increase in prostaglandin synthesis, which leads to all these effects. This COX-3, one of other isoform of cyclooxygenase, has been identified in brain, and if you suppress it, this is responsible for the pain and fever, not for inflammation. That's why the drug paracetamol, which inhibits COX-3, is having only analgesic and antipyretic effect, but no anti-inflammatory effects. Then let's classify NSAIDs into various classes. So according to the COX cyclooxygenase inhibitor, they can be classified into non-selective and selective. So non-selective may be, most of the NSAIDs are non-selective. They inhibit both COX-1 and COX-2. Now, in the COX-1 and COX-2, some are inhibiting COX-1 more than COX-2, such as aspirin, indomethacin, ibuprofen, piroxicam, and naproxen. Then some are in the non-selective, some are inhibiting more COX-2 than COX-1. So they are having lesser side effects than the previous one. And these are meloxicam, piroxicam, sulindac, and diclofenac. Then selective, for which are not affecting COX-1 and affecting only COX-2, are called coxiv, celecoxib, etoricoxib, rofecoxib, pericoxib, and then is selective COX-3. Only one drug is there, that is paracetamol, and it is having antipyretic and anti-inflammatory, antipyretic and analgesic effect, but no anti-inflammatory. Then based on the mode of cyclooxygenase inhibitor, they can be classified into irreversible inhibition or reversible. Irreversible means those which binds to the COX inhibitor and will not leave it free. So only one drug is there, that is aspirin. So it acetylates the COX enzyme, and then it will not be recovered. For recovery, the body has to produce new enzymes. And regarding second one is reversible inhibition, it is all the other one. So after sometimes their effect will be abolished. That's why a question is asked why aspirin should be stopped 1 week before surgical operation, while other NSAIDs stops after just 4 half-lives only, because the body requires to produce new cyclooxygenase enzyme, which will require 8 to or 7 to 10 days. Now, according to as I said in the second slide, that these are heterogeneous group. So based on the chemical structure, they can be classified into salicylate, example is aspirin, or indole derivative, indomethacin, or alkanones. This is, in front of alkanone, prodrug is written. It means this drug, nubutamol, itself is not active, but in the body it is metabolized into a active form. That's why it is called prodrug. Then mechanism of action, we have already seen. They inhibit cyclooxygenase enzyme, decreases the prostaglandin synthesis, and ultimately leads to antipyretic, anti-inflammatory, and analgesic effects. So antipyretic effect, which is induced because of the pyrexia, is induced because of the infection, hypersensitivity, malignancy, or inflammation. And WBC plays a great role. And pyrogen stimulates synthesis of cytokines. And these NSAIDs prevents the synthesis of prostaglandins by inhibiting COX-2 and decrease PGE2 in hypothalamus and reset the temperature point in the hypothalamus to normal, and ultimately leads to vasodilation, sweating, and loss of temperature. So the question is asked, can it affect the normal temperature? Answer is no. Then comes to the anti-inflammatory and analgesic effect of NSAIDs. They decrease prostaglandin by inhibiting COX-2 and decrease PGE2 and PGI2 that participates in the inflammatory process. So this suppresses only the symptom and signs of inflammation. You have to treat the cause of inflammation also. Then comes to the analgesic effect of NSAIDs. They have peripheral effect by COX-2 inhibition, and you have to treat the cause, plus there is decrease in PGE2. So there will be decreased peripheral sensory nerve stimulation. Second is central effect. It inhibits prostaglandin in CNS at subcortical area and at the level of spinal cord, thalamus, and hypothalamus also. It relieves a headache due to inhibition of vasodilatory action of prostaglandin in the CNS. That's why a question is asked, why? What is the mechanism by which these NSAIDs act in relieving headache? Beside this, other type of pains such as mild to moderate somatic pain, dental pain, arthritic pain, or pain due to vascular origin, dysmenorrhea, postpartum pain, cancer metastasis of bone, and postoperative pain can be inhibited by NSAIDs. We have seen they have effect on the platelet also. So these NSAIDs may have anti-platelet effects. Generally, platelets effect is because of thromboxane, inhibition of platelet aggregation. So aspirin produces this effect by inhibiting COX-1. And this inhibiting COX-1, which generates thromboxanes. So aspirin is the most effective platelet agent. Why? Because, as we have seen, it binds to the COX-1 irreversibly, means its effect is for a longer duration until the new cyclooxygenase enzyme is generated. That's why these are better than the other one. Other are all weak one. And these COX-2 selectives, such as celecoxib or rofecoxib or etoricoxib, are ineffective because they have no effect on the COX-1 itself. That's why COX-2 can increase platelet aggregation, because they inhibits this COX-2 and leads to decreased concentration of prostacyclins. Now, the effect on the kidney, so they are having various side effects such as nephrotoxicity, gastropathy, asthma, because of more leukotriene production. When this arachidonic acid not able to produce prostacyclin, it will be converted into leukotriene and causes the asthma. So these are having various disease state related to increased vasoconstriction. So they will having an effect on the renal, cardiovascular disease, nephrosis, and this is decreased volume may lead to increased vasoconstriction, angiotensin. So basically, if you see, they are having more effect on nephrotoxicity, they have gastropathy, and NSAID-induced asthma. Let's come to the point. The sheer adverse effect of NSAIDs. GIT, we have seen, it may lead to dyspepsia, heartburn, gastric ulceration. So this is more with the oral than the systemic. So how will you treat? If you are giving it orally, you should give it after the food. Or you can use selective COX-2. Or if you are giving non-selective, you should give proton pump inhibitor or H2 receptors blockers. These are the drugs which decreases the production of HCl in the GIT tract. Then kidney, irreversible effect is disturbance of renal function because of salt and water retention. It may lead to hyperkalemia and renal failure also. But there are some irreversible effects which are due to long-term use of high dose of analgesic or high dose of NSAIDs, and it may lead to analgesic. This is called analgesic abuse nephropathy. In elderly, there will be chances of cardiac and renal failure, so you should give it carefully. Then CVS, it may lead to hypertension, edema, congestive heart failure, and rarely it causes myocardial infarction because of thrombotic effect. You must have seen the thrombotic effect because of this COX inhibition. So it is best to give naproxen, which is having less side effects of cardiovascular system. Respiratory effect, it induces asthma in 5% of patients taking aspirin because it is inhibiting COX-1 only, and COX-2 is not inhibited. Then bleeding tendency, thrombosis, especially with COX-2, neutropenia, anemia, displacement of other drug from the protein, plasma protein can be seen. That is the drug-drug interaction. On the effect on the uterus, it may prolong pregnancy and may have teratogenic effect. Generally, it is class D in third trimester. Then skin, 10 to 15% of the patient may show hypersensitivity reaction such as urticaria, bronchoconstriction, and angioedema. And in liver, it may sometimes cause abnormal liver function test, increase in the liver enzyme, and the cause is unknown or idiosyncratic. Now, if you compare between non-selective and selective, so non-selective having more GIT effects, more gastritis, and selective is having less gastritis. In case of non-selective, which is inhibiting COX-1 and COX-2, there is more kidney impairment, where as in case of COX-2, it is less kidney impairment. In case of non-selective effect on the bleed, they have bleeding tendency and thrombosis, whereas in case of COX-2, there is only thrombosis. Lungs effect, so bronchoconstriction in case of a patient with bronchoasthma is seen with non-selective COX-2 and COX-1 and COX-2 inhibitor, whereas there is no effect on selective COX-2 inhibitor. It inhibits COX-2, so there will be no leukotriene production. So it will not produce any bronchoconstrictive effect. So they both are having cardiovascular risk. Increase in hypertension can be seen. So where these can be used? So these can be used as anti-inflammatory drugs, analgesic effect, and for antipyretic effect. Other than this, they can be used as antiplatelet. So aspirin is used as low doses because it is more effective, because it is irreversible effect, and it is used for inhibition of vascular occlusion. It can be used for the closure of patent ductus arteriosus. So this effect is seen in those patients, in those children when there is no closure of ductus arteriosus. So after the surgery, they can be given NSAID to close the ductus arteriosus. They are used in menorrhagia, reduction of colonic polyps, and prevention of colonic cancer, because long-term use of NSAID it has been seen that they prevent the colonic cancer. So even it has been seen that those patients who are taking NSAID for a longer time, they have reduced risk of Alzheimer's disease compared to those who are not taking. So let's see where NSAID should be given with precaution or are contraindicated. So these are contraindicated or should be given with precaution, especially the aspirin. Most commonly, aspirin exacerbate respiratory diseases, consists of bronchoconstriction and rhinitis, and this phenomena arise due to inhibition of COX-1. It may be, it has been seen that improper use may lead to peptic ulcer and upper gastrointestinal tract bleeding. They may lead to renal failure, especially COX-2 is constitutively expressed in the kidney, generating prostacyclin, which play an important part in the renal homeostasis. So these inhibits the prostacyclin. Then heart failure, because of the sodium and water retention and vasoconstriction, they may lead to heart failure. Hepatic failure, impairment of coagulation and increased bleeding risk by additionally inhibiting platelet function. Altogether, it may lead to hepatic failure. Hypertension and edema is also seen because of retention of water and sodium. And bronchial asthma is generally seen with non-selective because most of the electronic acid is converted into leukotrienes, and it may precipitate asthma in the patients. So during pregnancy, first and second trimester, we have already seen these are classified under category B and C, and third trimester, these are categorized under D. So these are safe in breastfeeding because these are not secreted in trace amount to the breast milk. So there are some slides regarding the aspirin and paracetamol. So we know that the aspirin inhibits COX-1 more than COX-2 and irreversibly. So their effect will be abolished only when new is formed. That's why it is explained why aspirin is used as antiplatelet effect, has more antiplatelet effect than other NSAIDs, because recovery required to take 8 to 12 days. Then indication, it can be used as antiplatelet effect at low doses, and it causes the decreased incidence of coronary artery thrombosis. It can be used as analgesics, but only in mild to moderate, not in severe visceral pain. It has antipyretic effects, anti-inflammatory effects. It can be used as prophylaxis in colonic and rectal, and even in Alzheimer's disease, because the chances of development is decreased. This can, in case of radiation therapy, prostaglandins may induce diarrhea. So we are using antiplatelet and COX-1 inhibitor drugs such as aspirin to reduce this diarrhea in radiation-induced patients. Then it can be used topically as a keratolytic for the acne, corns, callus wart, and it can be used for counter irritants such as methyl salicylate, and they have slight antifungal and antibacterial effect also that can be used for topical, not administration, oral. Side effects is generally seen with all the NSAIDs such as GIT effect on kidney, and bleeding, hypersensitivity, and idiosyncrasy. In idiosyncrasy, there is this is seen. Bleeding is seen with those patients who are having glucose 6-phosphate dehydrogenase deficiency. So this glucose 6-phosphate dehydrogenase is responsible for maintenance of RBCs. So in the absence of this aspirin may lead to hemolysis, and this is one of the side effects seen with the aspirin. The special effects, you must have studied this Ray's syndrome. If the patient, children less than 19 years of age, if given with the aspirin for the treatment of fever in case of viral infection, it may lead to Ray's disease. This may be fatal. Some people also shows salicylism. This is seen with chronic acid, and symptoms are tinnitus, vertigo, decrease hearing, nausea, and vomiting, but it disappears on stopping the drug. So if you see the side effects, you can say where it can be contraindicated. It can be contraindicated in bleeding tendency, especially in hemophilia, because in hemophilia, there is a deficiency in hemophilia A, there is deficiency of factor 8, and hemophilia B, there is deficiency of factor 9, and it is having antiplatelet effects, so it may lead to deficient bleeding. Peptic ulcer, we have already seen, it may lead to peptic ulceration, so you should not give it to peptic ulcer patient. Bronchial asthma, idiosyncrasy with G6PD deficiency, allergic, virus infection in children, because it may lead to Ray's syndrome. And last one is gout. Why it should not be given in patient having gout? Because it reduces urate excretion and interfere with the action of uricosuric drugs. Last one drug in this category is paracetamol. We know that it inhibits COX-3, another central cyclooxygenase enzymes in the brain. So it is decreasing pain and temperature also. It is not having any anti-inflammatory effect, and it is having no antiplatelet effect also. Other effects it produces is it stimulates serotonergic receptors, so it increases descending inhibitory pain pathway. It stimulates cannabinoid receptor also, so there will be decreased pain transmitter and decreases nitric oxide biosynthesis. So main effect is because of COX-3 inhibition. So it is safe in pregnancy, safe in children, it is safe in those persons who are having ulcer, bleeding, and kidney diseases. It is used for their analgesic and antipyretic effect, especially in children, because it do not cause Ray's syndrome. Ray's syndrome is seen only with those patients who are taking aspirin in the childhood. Then it is metabolized in the liver by phase 1 and phase 2. Phase 2 should come by after phase 1, but I have written this because this is very important. In normal doses, it is converted into when the person takes normal doses of paracetamol, it is converted into N-acetyl parabenzoquinone amine. This is conjugated with glutathione, and this non-toxic chemical is excreted. Conjugate is excreted out of the body. But what happens if somebody takes more dose? There is not enough glutathione. So what will happen? This will impair it causes liver and kidney toxicity. So how can you treat? You can give the patient some drug which can increase glutathione. So the drug is N-acetylcysteine that can be given intravenously or intravenously, or you can give oral methionine. These drugs increases the concentration of glutathione, and now glutathione can bind with this N-acetyl parabenzoquinone amine and will be excreted out of the body. Last one. This is the comparison between various commonly used analgesics. If you see, the drug which is having highest level of anti-inflammatory drug is indomethacin. Or even paracetamol is not having any anti-inflammatory effect. It is having only analgesic and antipyretic effect, but it do not show any bleeding. So you can use it to compare various NSAIDs. That's all for today. I hope you have written your name in the chat box. I will take the attendance from there. The two drugs, the two books, which are very good in description of all the things, is first one Cadson, and last one is Rangendale. You can consult all the other